a couple of minutes for the pre-webinar survey also?
Right. I'll just send the message.
Yes, ma'am. Thank you.
Is it possible to get the link to the webinar? Then more join actually.
Yes. Sure, ma'am. I can send it to you over the message also. I'll WhatsApp you.
Yeah.
Right.
पुलकित जो अंजनी ने शेयर किया है सबसे, वो क्या नहीं चलता?
मैम लिंक नहीं, वो लिंक टू रजिस्टर है. So many don't register at that time, and then once the link comes.
Last night, I think it was on the group. 256 have registered.
Yeah. But
so the link has to be given. Okay. Anyway.
Ma'am, I've shared the link with you again over WhatsApp.
No, Aisha, this is the register wali link. Can we share the link?
This is the link, ma'am. Once we register, and then it will send you to the Zoom meeting. So the registration is important, ma'am.
Okay.
Hello, Dr. Kapil.
Good morning, Dr. Kapil.
Good morning, ma'am. Good morning. How are you, Dr. Pulkit?
Good, sir.
Sir, आप पुलकित को जवाब दे रहे हो, मेरे को नहीं दे रहे हो? Am I not audible? No.
No, you're audible, ma'am.
अच्छा.
Ma'am, I've again shared the webinar ID and passcode for the students to directly join the webinar now.
Okay.
Before we formally begin, I would request all the participants to please fill the pre-webinar questionnaire. The link will be posted in your chat boxes and also visible on the screens, I believe. There's a QR code alternatively that you can scan. It will just take a couple of minutes, just 2-3 minutes to do that. And I would like to also inform you that there is going to be a post-webinar survey as well. I request you to fill both of those in order to get your certificates. Those shall be delivered to you within 3 days. Kindly fill this, and then we'll send the link as well in the chat box. That has been posted as well. So please locate it and please fill the survey. Once again, I would request all the participants to please fill the pre-webinar survey. It is mentioned in the chat box, also visible on your screens. Alternatively, there is a QR code available. You can scan it and fill the survey. There will be a post-webinar survey as well. I request you to fill both the surveys in order to get your certificates. Certificates will be delivered in your mailboxes within 3 working days. Ma'am, can we start? I think we have around 89-90 participants as of now, and already 11. So if you allow, then maybe we can start.
So we can start.
Increase to 106. The participants are 106 now.
So I think we can begin. Good morning, everybody. Viral hepatitis, as you know, is a global public health problem. And this is particularly true in resource-poor countries. It is estimated that complications of hepatitis B and C infections, they actually lead to nearly 1.4 million deaths, which is like higher than the deaths caused due to tuberculosis, malaria, and HIV put together. A very, very warm welcome to all participants who have joined us today for this national webinar on recent advances in the prevention and control of hepatitis B and C. Lady Irwin College, University of Delhi, joins hands with Institute of Liver and Biliary Sciences in organizing this very important webinar, which is an initiative for the prevention and control of viral hepatitis in India. Lady Irwin College, established in 1932, is a premier institute of home science education in India. It is accredited as NAC A+ and has an NIRF rank of 24 among more than 4,000 colleges in India. The Institute of Liver and Biliary Sciences is a deemed university under UGC established by the government of NCT of Delhi. It is an international center of excellence dedicated to the field of specialized healthcare for the treatment and prevention of liver diseases, including hepatitis. So some of you may be aware that about 60 million Indians are actually infected with hepatitis B and C viruses, which are responsible for liver cirrhosis and cancer. Now, the epidemic of these infections is often referred to as a silent epidemic because many patients are not even aware of the infection status. And many cases, they just go unrecognized and untreated for many years. It is understood that majority are harboring the infection and they are undiagnosed and they are totally unaware of this status. Several initiatives are currently being undertaken by the government under the National Viral Hepatitis Control Program to improve access to vaccines, diagnostics, and the treatment for such individuals and those who are at risk. However, there is a stigma attached to it, and consequently, a lot of discrimination which is associated with these infections. And this kind of proves to be a hindrance to care seeking, compliance, and also mainstreaming. The infected, very often, they don't want to even be identified for the fear of social isolation. Empowering people against hepatitis, also known as the Empathy Campaign, is being implemented by ILBS. And this is like a project which is funded by the Airports Authority of India under its corporate social responsibility. Now, this is one such attempt to spread awareness about hepatitis B and C and to address the stigma which is associated with the disease. Through this webinar today, we hope to sensitize all the participants about the magnitude of the problem and how this virus is actually transmitted. And that will help us to understand how the spread can be prevented at the community level. It is also vital for us to understand how the screening can be done. How can people be identified whether they are affected or not affected by this virus? How to educate the community at large about the vaccines which are available to prevent this, and also other measures which can protect our livers and keep our livers healthy. With that, I invite Dr. Anupa Sidhu, who will be delivering the keynote address. Just to introduce Dr. Sidhu. Yeah. Just give me a minute to share screen. Is my screen visible?
Yes, ma'am.
Okay. Dr. Anupa Sidhu is the director, Lady Irwin College, University of Delhi. She is a PhD from AIIMS, a gold medalist, and under her dynamic leadership, Lady Irwin College has received several awards and accolades. She is the chairperson, National Center of Excellence and Advanced Research on Diets, and also the chairperson for the National Center of Women Collectives-led Social Action at Lady Irwin College. She was National Head Secretariat Capacity Building Project, which was a big multi-centric study that was done on food and drug safety. She is also a signatory to several MOUs with foreign universities. She is the recipient of several awards like the Mahila Shiromani Swarn Padak Award, the Karam Ratna Award, Shikshak Ratna Award, International Education and Leadership Summit Award, just to name a few. She is also a member of several professional bodies, national committees, and scientific committees on policies on food safety, nutrition, and nutrition security. Dr. Anupa Sidhu.
Thank you, Pulkit. Can I now share my screen if it is free? Yeah. Why is it not coming on the presentation mode now? Yeah. So I want to thank Dr. Serene, Professor Serene, Professor Umesh Kapil for launching onto this, embarking on this new journey. And I know that there are several webinars held already on the subject. And ILBS has a mandate to do this work of awareness on hepatitis. And in this particular webinar, Lady Irwin College partners with Institute of Liver and Biliary Sciences to organize this national seminar on recent advances in prevention and control of hepatitis B and C. I just want to, although well known, but I just want to recapitulate for the sake of our students and many other delegates who are there. We are talking out of A, B, C, D, E, although that is all of them are covered under the national program, but we are particularly focusing B and C in today's seminar. And A has been very common, very contagious, a viral hepatitis and well known. And many of the others are latent and are silent. And for example, the hepatitis D, which is the delta hepatitis, happens along with B, hepatitis B, which is highly contagious, happens through body fluids, somewhat the same routes. But if we understand both of this, most of the prevention is taken care of. And these are the two under the focus right now. And I'll tell you why the emergence has come up from the various national state-wise data. I'll not make it heavy with data and statistics, but I'm just trying to center stage the issue. The hepatitis B is spread by person-to-person contact through blood and body fluids. And it generally spreads through unprotected sex or by sharing needles to inject drugs. these drugs, some of them are abusive in nature, and otherwise these could be general drugs at the time of injections. And you having an unsafe practice on using, not correct protocols of using needles, multiple use of new needles are some of the issues which are troubling a person. And blood from hepatitis C is by blood of infected people. It is particularly concentrated in the blood. So it is usually through blood-to-blood contamination by contaminated needles and other equipment used for injectable drugs. The disease has I am finding, I would like to change the layout. Can you tell me how do I remove the faces from the, yeah, now I can see that. How do I don't see the, I see them on the top, if possible. Pulkit, Manita, what is the way to do it? Just remove the checker. Right now on thumbnail, active speaker video. And what if I don't want the video at all? Is that option there? Hide thumbnail, hide, okay. Yeah, fair enough. I've been able to hide them all. All right, so disease burden of hepatitis B. Now, India has intermediate to high endemicity of hepatitis B surface antigen and an estimated 40 million people with this virus, constituting approximately 11% of the global burden. That's no mean amount, but this is how it is understood as of now by available data. Population prevalence of the HPV infection is around 3 to 4%, and there is wide variation in the antigen prevalence in different geographic regions in India, with highest prevalence recorded in Andaman and Arunachal Pradesh. These are the two places where there is a little high amount of tribal groups, and therefore you find this a little more concentrated. And when you have this antigen prevalence, then that is the active infective stage. Otherwise, it is also anti-AB, which is antibody prevalence also, which talks about potential protection. So on one meta-analysis, the point prevalence of hepatitis B in non-tribal population was found to be 2.1%, and this corresponded to a chronic hepatitis B infection. Among the tribal population, the point of prevalence was 19.4 in the group studied, and this corresponded to the infection rate of 15.5%. There are also state-wise differences, tribe to tribe differences. Where is this one? So we then go on to hepatitis C. The prevalence of hepatitis C infection in India is around 1%. However, there are pockets of areas where the prevalence has been relatively high, like Punjab, Haryana, Andhra Pradesh, Puducherry, Arunachal Pradesh, and Mizoram, by and large by injecting drug users, even truckers and attendees of sexually transmitted infections, persons suffering from thalassemia, hemophilia, which have a lot of blood transfusions from time to time in their management, and a high risk believed to have led to relatively higher prevalence of the condition in particular area. In a recent study in Punjab, 5.2% prevalence of hepatitis C infection, the risk factors of acquiring this infection were identified to be history of surgery, a dental treatment, or unprotected sex. Lack of awareness coupled with unscrupulous practices of healthcare providers have led to an alarming 22.6% of the population sample being infected with hepatitis C in a particular block in Haryana. The prevalence of the hepatitis C in Arunachal Pradesh is 7.89%. Mizoram, the prevalence of the hepatitis C is 71% among the active cases studied. It has been noted that unsafe behavior among injecting drug users is the driving factor behind HCV epidemic in Northeast India. In some studies conducted in Andhra Pradesh, the cultural practices such as tattooing, traditional medicine, that is bloodletting, rituals among pilgrims, and 4% body piercing having been observed to lead to a significantly higher rate of hepatitis C transmission. And the prevalence rate of 1.4 to 6 have been noted in different studies conducted in tribal and other populations of Andhra Pradesh. Now, these are data by and large from the health statistics of the government. It's from government data. And it further goes on to say that a meta-analysis of hepatitis C prevalence was undertaken by SGPGI Lucknow. The study documented a pool prevalence of hepatitis C among various subpopulations. This meta-analysis concluded that based on above studies, it is estimated in India's population to about a current population of 1.3 billion, means that 5 to 13 million hepatitis C positive persons are already there. Now, this is data from WHO. It's talking about the global disease estimate of hepatitis A, B, C, and E, and it can also lead to cancer and cirrhosis. So these are the data, prevalence data based on that, which is, so the viral hepatitis contributes to nearly 2.85% of the total deaths in India, and total death of all causes could be much higher in a number. The percentage due to viral hepatitis is 2.85 to conclude. Recent data on disease burden. This is from basically some research data about 2.57 million persons infected with the chronic hepatitis. And it leads to up to 8.8 lakh deaths annually. More than 90% of the death and disability as a result of viral hepatitis is attributable to the CHB and chronic hepatitis C infections. WHO approved the strategy to eliminate viral hepatitis as a public health threat by 2030. And so this is a target set for global purposes. Obviously, India is part of it, which requires that new CHB is reduced by 90% and mortality attributable to CHB is reduced by 65%. India falls in the intermediate hepatitis B virus endemicity with prevalence rate of 2 to 4 in the general population, and transmission is believed to be mostly occurring horizontally during early childhood by physical contact, although up to 30% of the cases are due to vertical transmission. And India harbors 10 to 15% of the global pool of the B virus and has 40 million B virus carriers, of whom 15 to 25% develop cirrhosis and complication, leading to healthcare cost and premature death. To continue the recent data on disease burden, there is heterogeneous population and prevalence of the B virus, estimated to be 2.4, as I said earlier, and tribal area as high as 15.9. In Ladakh, it is 12.7, Arunachal Pradesh 21.2, Nicobar 23.3, and 37% and 65% in the tribes of Andaman and Nicobar Islands. Another cause for spread is unsafe injections and reuse of syringes or needles. And 16 billion injections are prescribed annually worldwide. More than half are unsafe, which is a huge number. And one needs to understand when we do this, what's the whole idea of visiting this is, what are the causes and what are the barriers and promoters? And this looks like one major reason of unsafe injections. And India contributes to 25% to 30% of the global load with the frequency of 2.9 injections per person. Casualty can be attributed to unsafe injections in 46 and 38% of cases of the B virus and the C virus. So the National Viral Hepatitis Control Program has embarked on this journey. This has been launched by Ministry of Health and Family Welfare on the occasion of the World Hepatitis Day on 28th July 2018. It is an integrated initiative for the prevention and control of viral hepatitis in India to achieve Sustainable Development Goal 3.3. So it is woven into the goal, the Sustainable Development Goal, because a lot of endemic and hidden and with stigma, this is, looking like a massive, you see, in a huge, in a population-rich planet, a small percentage rise is affecting quite a number of people. So this is a comprehensive plan covering the entire gamut of A, B, C, D, and E, and the whole range from prevention, detection, treatment to mapping treatment outcomes. Operational guidelines for National Viral Hepatitis Control Program, National Laboratory Guidelines for Viral Hepatitis Testing, National Guidelines for Diagnostic and Management of Viral Hepatitis are also being released by the national program. The main aim of the program is combat hepatitis and achieve countrywide elimination of hepatitis C by 2030. Achieve significant reduction in the infected population, morbidity, mortality associated with hepatitis B and C, which includes things like, the normal complications of liver like cirrhosis and hepatocellular carcinoma. Reduce the risk of morbidity and mortality due to A and E also is within its aim. So it deals with the national program deals with all. We are today only talking B and C with a larger focus. The key objectives of the national program is enhance community awareness. So this is the first step. People should know about it. There's no point hiding behind the bush or closing one's eye to eventualities. One should be aware and of the issue on hepatitis, lay stress on prevention among the general population, especially the high-risk group and in hotspots. Provide early diagnosis, management of the viral hepatitis at all levels of healthcare, develop standard diagnostic and treatment protocols for management of viral hepatitis and its complication, strengthening existing infrastructure, capacities, of increasing the human resource and raise additional human resource also where required for providing comprehensive services for management of viral hepatitis and its complications. Also, one of the key objectives is develop linkages with the existing national programs towards awareness, prevention, diagnosis, treatment of the viral hepatitis, and develop a web-based viral hepatitis information management system to maintain a registry of persons affected with the hepatitis and its sequelae. Somehow the web-based systems and the large management systems are becoming important. This enables two ways that you're able to reach the unreached and you're also able to collect the response from them. And almost everybody has a smartphone and one is able to, and everybody is savvy to this. It's important, therefore, to run this information management system with great integrity so that one is able to reach out to people correctly and create databases. And whatever are the interventions, one is able to record, this is monitoring the program, one is able to record what incremental advantage we have done, maybe by number one, awareness, maybe by any preventive technique, any special diagnostic system, or a treatment system. The components of this program are fourfold. First, the preventive component, and this is the cornerstone of the national program. It includes awareness, general awareness, and behavior change communication. So there's no point having awareness if it doesn't translate into behavior. All of us used to do research on KABP, knowledge, attitude, and practices. And behavior is becoming now an important one. If that doesn't change, the practice does not change. So one needs to understand these. Immunization of hepatitis B at the time of birth, or a high-risk group, or a healthcare worker is also one preventive component. Safety of the blood and blood products, injection safety, safe socio-cultural practices, and safe drinking water. Especially hygiene is now getting in a big way. So hygiene brings a significant advantage in prevention of the hepatitis and the toilets. So basically hygiene has to be plays a very important role, and safe drinking water and things like hepatitis A, which is by and large by food and water transmission. So those are all the types of hepatitis should be prevented, although we are talking about two. Diagnosis and treatment, screening of the pregnant women. Just give me a second. Screening of pregnant women for the antigen to be done in areas where institutional deliveries take place, and referral for institutional deliveries so that the vaccine takes place. Full screening, diagnosis, treatment of both B and C would be made available at all levels of healthcare in a phased manner, and provision of linkages, including with private sector and not-for-profit institutions for diagnosis and treatment. Engagement with community peer support group to enhance and ensure adherence to treatment and demand generation. The third component is monitoring and evaluation, surveillance, and research. Effective linkages for surveillance would be established according to the program, and operation research would be undertaken through the Department of Health. Standardized monitoring and evaluation framework would be developed, and an online web-based system. So as I said just now, that there's no point having a program if we did not bring about awareness, we did not monitor and we did not communicate through a behavior change communication. Everything, I talk from a prism of nutrition. Nutrition education doesn't take place anymore without Jan Andolan or an Abhiyan. So these are all behavior change communication. There are components of behavior change communication, and there are very specified techniques to measure it. So if we have a national program, we should be able to monitor. And one good method of monitoring is through ICT on a web-based system. And that tool should be very sharp and pick up the cases carefully and categorize them also. Training and capacity building. This will be a continuous process according to the program and will be supported by the National Center for Disease Control. And in the first few slides, I gave data from this center, and ILBS, Institute of Liver and Biliary Sciences, who has partnered today, has taken the initiative, is an integral part of the program, and state tertiary care institutes and coordinated by the program, the national program. The hepatitis inducted and update programs for all levels of healthcare workers would be made available using both the traditional cascade model of training through master trainers and various platforms available for enabling electronic e-learning and e-courses. So this is training and capacity building at a higher level with large number of care workers and with few number of care workers, self-paced learning on e-platforms, and this should be used as a major model of awareness among health functionaries and apart from the health from the communities at large. So in today's, as I said, today's initiative is something which is organized by Lady Owen College in collaboration with ILBS, with their initiative, with the ILBS initiative. They have the mandate for it, and ILBS is a deemed university, and this I'm telling for the advantage of our students and our delegates, and an international center of excellence in the field of specialized healthcare and research in liver disorders, including viral hepatitis. Lady Owen College is also a host for today's webinars with ILBS. It is NAC A+ accredited institution with a national rank of 24 nationally, and works on several community-based projects for the Ministry of Health, Department of Food and Nutrition hosts the National Center of Excellence and Advanced Research on Diets. Team Empathy, which today's program is a campaign project through Empathy, and which stands for Empowering People Against Hepatitis. So I acknowledge profusely Professor Serene, Director ILBS, Professor Umesh Kapil from ILBS and his team, and the Empathy Campaign team, project people, and the Social Responsibility of Airport Authority of India for bringing up this on the platform of larger number of students and faculty and research workers working in the area of health communication, health and nutrition communication at large, and for bringing about maximum awareness. So once the hepatitis sets in, all hepatitis by the terms of diet will be treated in a particular manner, and for the dietary intervention part is once the hepatitis take place. So today's campaign is to prevent it and therefore awareness. Needless to say that the national program is committed for diagnosis and treatment, and that can be dealt at any other stage. But there are specific diets for liver disorders, and it does not differentiate between various categories. And many of the strains, A, B, C, D, and E strains, each one has their own trajectory. For example, hepatitis B, you become a carrier, and it becomes a chronic, long-lasting kind of an infection, although the severe infection goes away in 4 to 8 weeks. Hepatitis C, it takes about 2 to 6 days to 6 months to clear up on oral medication, and half the people don't even come to know, and it takes decades to disappear. There is no vaccine for C, but there is a vaccine for B, and I hope the other panelists will bring out these finer nuances about the various strains. I already said about hepatitis D. It is present a lot in Europe, Africa, and South America, and it is contagious and through body fluids and occurs with B. And A is preventable completely. It's a liver infection found in the fecal matter, and spreads through contaminated food and drink, and the symptoms last about 2 months and can be prevented by a vaccine. Hepatitis E leads to swelling up of the liver, does not lead to any long-term illness or liver damage, but still it should be prevented, and it takes a few months to heal up and continue, and it affects the liver, and we must maintain high integrity of the powerhouse of human body or animal body, which is liver, which decides all the pathways of metabolism, defense, and storage. So we, in the spirit of a healthy liver, present this collaborative work from Lady Irwin College with ILBS to you. Welcome.
Thank you, Professor Sidhu, for this very, very informative keynote address. You have given a very, very detailed overview of all the types of hepatitis and the way forward. I now invite Dr. Manya Prasad to present the burden of hepatitis B and C in India. Just to introduce her, she's Assistant Professor Clinical Research Epidemiology at the Institute of Liver and Biliary Sciences, New Delhi. She has about 35 international and national articles in Medline Index journals, and an H index of 15 and an I-10 index of 21. Her areas of interest include epidemiology, medical research, systematic reviews and meta-analyses, evidence-based medicine. She has facilitated many workshops on research methodology, evidence-based medicine, and grade tool. She's a gold medalist in her MD final exam and the recipient of International Epidemiology Association Fellowship. Dr. Manya Prasad.
Thank you. Thank you so much, ma'am. And I extend my heartfelt gratitude to Lady Irwin College, to Anupa Sidhu ma'am and Pulkit Mathur ma'am for jointly collaborating with ILBS for this very important webinar. I hope this initiative goes a long way in strengthening the government's efforts for hepatitis elimination. And I also thank the attendees for taking out the time to participate today. So without much ado, I'll get right down to the presentation. And what I am going to talk about is the current disease burden in India of hepatitis B and C. Anupa Sidhu ma'am has very wonderfully summarized on this topic in her keynote address. It was so wonderful listening to her, and certainly it's made my job a lot easier. But what I will go through are the reported estimates of the prevalence of chronic infection in India. We'll do a bit of a critical review of the current literature, provide estimates from recent studies, talk about the rate of liver complications with hepatitis B and C, and finish with some steps needed. So, needless to say, the liver is a very important organ in the body. It's situated right here in the upper right quadrant of the abdomen. And day in and day out, it performs a whole array of functions. It's really a metabolic factory, has so many important functions in the body. What damages the liver? Well, primarily there are three things that can damage the liver. The first one is probably the most talked about with regard to liver-related morbidity, and that's alcohol. Alcoholic liver disease, certainly, big problem globally as well as in India. The next thing that can damage the liver is fat. So non-alcoholic fatty liver disease, or NAFLD, is soon to overtake all other causes of chronic liver disease. In fact, NAFLD is the most common chronic liver disease worldwide and is a very important cause of liver transplantation and hepatocellular carcinoma as well. So again, fat, a very important cause. And the third thing is what we're going to be talking about today, which is some viruses can damage the liver. And apart from this, there are some rare causes like autoimmune diseases and so on. So there are primarily 5 types of hepatitis, as alluded to by ma'am, just like the 5 fingers in our hand, A, B, C, D, and E. And the modes of transmission will be talked about in detail by the next speaker. But just tell you here that A and E are the types of hepatitis that are transmitted through contaminated food and water. And B, C, and D have parenteral transmission, so bloodborne through body fluids, sexually transmitted, and so on. So why do we need to talk about hepatitis? And what is the big deal with all of these webinars that are being conducted through this campaign? Well, we need to think about this because it's one of the leading causes of mortality worldwide. And it's certainly a very important public health problem in Southeast Asia, of which India is a part. It's one communicable disease where mortality is actually observed to be increasing. So if we observe the trend from 2000 to 2015, mortality from HIV, tuberculosis was reducing, but that favorable trend was not observed for hepatitis. So deaths were actually increasing by a substantial amount. It's responsible for as many, if not more, deaths annually than TB, AIDS, or malaria. And around 90% of these deaths are due to hepatitis B and C infections. We also need to think about this because this is something that we can actually do something about. So hepatitis is amenable to prevention and control. We have a very, very effective vaccine for hepatitis B. We talk about efficacy of COVID vaccines and we say 70% to 75%. Here we have a vaccine that's 95% or more effective. And for hepatitis C, we actually have a cure now. So, this is something that can be prevented and controlled. And so we need to bring our focus back on hepatitis. With regard to the pandemic, COVID-19 has posed a major challenge in achieving hepatitis elimination. So, the best by interventions for hepatitis elimination, like vaccination, health education, and screening, they've been severely interrupted during the lockdowns. And it's been documented that hepatitis has suffered amongst the highest destruction of all diseases. And this has been more than that for even HIV, malaria, and tuberculosis. So the last World Hepatitis Day, which was 28 July 2021, the slogan for that was actually hepatitis can't wait. So while we're running around, detracting resources from other diseases to meet the challenges of COVID-19, this is actually something that requires us to focus our attention back to it again. So very importantly, when we talk about the burden of hepatitis, what we're concerned about is not just the acute infection. So very often, what happens with other types of hepatitis, A and E particularly, is that there's an acute illness, so the patient suffers from fever, jaundice, malaise for a few weeks or some days, and then recovers and goes about their business normally. Whereas with hepatitis B and C, the challenge is that it results in chronic inflammation in the liver. So this infection lingers on for many, many months and years. With long-standing inflammation, what happens in the liver is that healthy liver tissue gets replaced by scar tissue. So that's fibrosis. And long-standing fibrosis can lead to irreversible damage in the liver. So that's liver cirrhosis. You can see here the scarring and the shrinkage of the liver. And this is permanent damage. And over many, many years, cirrhosis can lead to, and does lead to, in many cases, hepatocellular carcinoma, that's liver cancer. And so these two liver complications, cirrhosis and hepatocellular carcinoma, very, very important in terms of burden for mortality and morbidity. The very expensive diseases to treat, and of course, with regard to prognosis, I don't need to tell you that it's certainly very, very scary. And so these are the two complications that are most relevant in terms of burden of hepatitis B and C. So this was again already alluded to by ma'am, but let me just focus on the details. If you come down to the numbers, there are worldwide 296 million people living with chronic hepatitis B and 68 million with chronic hepatitis C. WHO estimated that this accounts for around 1.4 million deaths worldwide. And these deaths, cirrhosis resulted in around 820,000 deaths, and hepatocellular carcinoma. So cirrhosis and hepatocellular carcinoma together accounts for 820,000 deaths. Up to 40% of those with chronic hepatitis virus develop sequelae during their lifetime. So cirrhosis and hepatocellular carcinoma, with cirrhosis accounting for 720,000 of these deaths and HCC for around 500,000 deaths. So big numbers there in terms of burden for mortality and morbidity. So this shows the spread of infections across the WHO regions. And you will observe that there are some regions that are affected more than others. So Western Pacific and African regions. But then Southeast Asia, of which India is a part, 60 million cases, high burden here as well. So that's for hepatitis B. And for hepatitis C, again, we see a gradient across WHO regions, with some regions suffering more, and 10 million cases for the Southeast Asia region. Within the Southeast Asia region, the way that the burden of hepatitis B, chronic hepatitis B, is measured is by measuring the surface antigen. So we measure the prevalence of surface antigen, and within the Southeast Asia region, there is again disparity with regard to some countries suffering more, like Bangladesh, Myanmar, Thailand, etc. And this is mostly because of high rate of mother-to-child transmission of the virus. And we will see in future sessions that birth dose vaccination is actually one of the best methods to reduce the burden. And India also has very low coverage of birth dose vaccination in a lot of districts. So that's one place that has to be targeted. With regard to prevalence of HCV, again, we see that some countries suffering more than others. And I'll talk more about the Indian estimate in the next slide. So if we talk about India, the estimate for prevalence of chronic hepatitis B comes from 3 research groups mainly. The first is the paper by Schweitzer et al., which was published in the Lancet in 2015. The second is the WHO estimate, which engaged a number of agencies and to synthesize the pooled estimate. And third is the CDA Polaris group. And over here, you'll see that there's a point estimate that's reported. That's the figure in the middle. So that's sort of the best guess from the data. And then in the brackets, we have our confidence interval. So this is sort of like the margin of error for the data that's there. So you'll see here that the estimate is around just under 2% from these studies. The CDA Polaris group, little higher, but then strong overlap in confidence intervals of these estimates. And then compared to the worldwide estimate, you can see how India compares. If you're wondering what these research groups did, they've all synthesized the evidence from peer-reviewed literature. So these are the databases they looked in, and probably they sound familiar because this is where you go to look for evidence on nutrition studies. And the reason that the point estimates and the confidence intervals differ a little bit is probably because of the kind of individuals in the studies that they included. So there's some discrepancy with regard to the countries that are enrolled in pooling of the estimate. Most of them excluded non-representative individuals from arriving at the estimate. So this is purported to be the most reliable one currently. The Schweitzer paper, which included 129 studies and 3.7 million subjects, and estimated around 17 million chronic carriers in India. If we compare the time trend, so 1950s to 1980s compared to the decade later, we will see that there has been a reduction in prevalence of chronic hepatitis B. So 2.62 for 1957 to 89 and 1.44 for 1990 to 2013. And this can probably be attributed to vaccination, so universal immunization that's included in the program. This is also corroborated by the WHO estimate. So if we compare the pre-vaccination estimate to 2019, there has been a reduction, and this can maybe be attributed to vaccination. If we take a look, just a snapshot at recent studies, what is pertinent to mention here is that mostly they are subnational studies, and they have high heterogeneity with regard to the kind of individuals that are enrolled. So some are in general population, some in healthcare workers, some in patients, and so on. And also the testing method differs quite a lot, which is probably why the prevalence reported is little discrepant across these countries. So there's still a requirement of a very good, robust, nationally representative survey, which recently has revealed some results, but has to be subjected to a critical appraisal of methodology. So these are the recent studies. And coming on to the prevalence of chronic hepatitis C, this is again a systematic review which reported that if you just look at community-based studies in general population, blood donors, and pregnant women, the estimate is 0.85%, which accounts for 6 to 12 million chronic Hcv infected individuals in India. And chronic Hcv infection accounts for up to 32% of hepatocellular carcinoma and 20% of cirrhosis. So a very important cause for, again, these two severe complications. So you can tell from what I told you that, there are limitations in the current literature with regard to estimating prevalence and burden. Their quality of reporting is variable. We have a combination of robust and non-representative studies done in different age groups. We don't have data, very strong data on age-specific and sex-specific estimates. So, if you ask me whether gender modifies the estimate, we don't have that kind of data. Some studies are done on blood donors, which may be an underestimate because healthier people are expected to come for blood donation. And mostly studies are subnational, with some in very high endemicity areas like tribal. If you talk about the mortality from hepatitis B alone, what this graph depicts is the number of deaths from hepatocellular carcinoma, cirrhosis, and acute hepatitis in each type of hepatitis. So if you just look at hepatitis B and C, the lightly colored portion is the deaths from hepatocellular carcinoma. The dark shaded one is cirrhosis, and the very darkly shaded one is acute hepatitis. And you can tell that most of the deaths, large chunk of deaths in both chronic hepatitis B and C are due to hepatocellular carcinoma and cirrhosis. And if you look at the absolute numbers, again, a high burden there. So mortality estimates by cause in 2016 revealed 141,000 liver cirrhosis deaths due to Hep B, which accounts for 7.8 per 100,000. So this is the 8th standardized death rate. This was a paper that came out of the Global Burden of Disease study, which tells the percentage change from 2007 to 2017 of incidence of liver complications. So that includes both cirrhosis and hepatocellular carcinoma, and the death rate from those liver complications. So the global trend, at least the point estimate, it suggested a reduction, so a 2.5% reduction between these 2 years. But then the estimate for India, worryingly, was an increase, a 7% increase. But then the confidence interval suggests that this is not a very reliable estimate. And the big caveat here, of course, is that this relies on global, the cause of death certification, which is very poor for India. And this trend also holds true for liver cancer and liver cirrhosis individually. So seeing that trend and that burden, the World Health Organization drafted the Global Health Sector Strategy 2016-2021 and also has extended it to achieve elimination by 2030. So what this entails is a 65% reduction in deaths from chronic hepatitis B and C by 2030, and a 90% reduction in new cases of chronic hepatitis B and C by 2030. Now, the only way that this can be achieved is through a public health approach, and we need a concerted, collaborative effort from all lines within the medical discipline and allied health disciplines, and that's the only way they can be achieved. And thank you very much for your attention. And we can take all questions in the if you post them in the Q&A box. Thank you very much, and back to you, Pulkit ma'am.
Thank you, Dr. Manya. Thank you for actually highlighting the need for comprehensive data generation in the country. And now we move on. I would like to invite Dr. Kanika Kaushal to present her talk on transmission and prevention of the hepatitis B and C virus at the community level. Just to introduce Dr. Kanika.
Hello, good afternoon.
Yeah, Dr. Kanika Kaushal is an assistant professor of epidemiology. She has also worked as a technical officer at South Asia Field Epidemiology and Technology Network. Before, recently joining ILBS in October 2021, she has worked as a technical officer at the South Asia Field Epidemiology and Technology Network, which is an international organization funded by United States Center for Disease Control and Prevention, Atlanta, US, for the India Epidemic Intelligence Service Program. She managed the India EIS program for National Center for Disease Control, Delhi, and worked actively in various COVID-19 related outbreak investigations and surveillance activities since March 2020. She has also worked in the digital health space during her tenure at PGI-MER Chandigarh, where the team successfully helped set up the electronic health records in a public health dispensary from scratch in collaboration with HISP India for outpatient services to the slum population of Chandigarh. She has also implemented the smart technology in a small village of district Panchkula, Haryana, where they checked the feasibility and utilization of mobile-based smart technology for chronic hypertensive and diabetic patients in a resource-constrained setting at a rural healthcare post in North India. She has published over 50 research articles in various national and international journals. Dr. Kanika, the floor is yours.
Thank you, ma'am. Can you see my presentation?
Yes.
So the topic, okay. So today I'll be going through the transmission and prevention of hepatitis B and C at the community level. First, the modes of transmission of hepatitis B and C, and then the strategies for prevention of transmission. So I'll be going through the general precautions for Hep B and C together, and then the vaccination and post-exposure prophylaxis for hepatitis B. So hepatitis viruses, they are hepatitis A, B, C, D, and E. So hepatitis A and E are transmitted enterically via fecal-oral route, food, or water. And hepatitis B, C, and D virus are these are the parenterally transmitted viruses. So these the routes are either blood-borne, which is that after the transfusion of blood or blood products, or other nosocomial routes where dialysis, unsafe injections, needle stick injuries, or the surgical, various dental procedures, organ transplantations. Then sharing of needles among persons who inject drugs, sexual route, perinatal from mother to child, that is the vertical transmission, or the horizontal transmission amongst household contacts, children. So these are the common routes for hepatitis B, C, and D. So talking about the common routes for hepatitis B virus first. So first and foremost, perinatal transmission from mother to child, and after that these routes which we already enumerated. So the hepatitis B virus, this is the like if we talk from the most common route of transmission and coming down to other routes. So these are hepatitis B virus. So infections during infancy and early childhood are particularly likely to lead to chronic infection with risk of cirrhosis and death. So if we see that as from birth to getting to older children and adults, so if they acquire infection here at the birth from perinatal route from mother to child, so the chances of chronicity are at the highest. And as the age of acquiring this infection, as we acquire the infection as we grow up, the chances of chronicity decreases. So there's a relation between the chronicity and the acquisition of this virus. Then vaccination is the key intervention to prevent chronic hepatitis B infection, since this commonly occurs following infection during infancy and childhood. So we need to prevent that early mother to child infection. So there, in the next presentation, we'll go in detail about these vaccinations. So just to give you a premise, so childhood vaccination is primary 3-dose vaccination which we talk about, like birth dose is 0 dose, and then we, as a part of the pentavalent or hexavalent vaccines, we go for 6 weeks, 10 weeks, and 14 weeks of immunization here. So the key is the timely birth dose of hepatitis B within 24 hours when a child is born. So the childhood vaccination holds an important center point in prevention of HPV infection, and then reducing the chronic HPV infection in future. Then vaccination of healthcare workers, like doctors, nursing staff, etc., and the high risk groups like people who inject drugs and other high risk groups. And other measures apart from vaccination are, of course, screening of they lie in sync with the modes of transmission that we talked about. So screening of blood and blood products, injection safety, occupational safety at workplace, harm reduction intervention, and safe sexual practices. So this is the in immunization, primary 3-dose vaccination of hepatitis B in infancy. So first is the 0 dose, which I said, like within 24 hours, and then at 6 weeks, 6 and 10 weeks, and 6, 10, or 14. So this is what we are aiming at: 6, 10, and 14 weeks with 98 to 100% protection. So then again, it is the same thing, that timely, to just reiterate, that administration of the first dose of hepatitis B vaccine within 24 hours of birth is what we are aiming at. As of today, like if you are not sure whether you have received the dose of hepatitis B in your infancy, or whether even adult immunization, so what you can do is get your anti-HBs titers checked. And if the serum level is more than equal to 10, so that means that you are protected against hepatitis B. So this is the cutoff which we use to define the vaccine response. So over 90% of the vaccine responders, they remain protected for at least 30 years, irrespective of whether anti-HBs antibody remains detectable or not. So booster doses of hepatitis B vaccine are not needed. So these are the, as per WHO, UNICEF joint reporting, this is where Southeast Asia region is in infant hepatitis B vaccine coverage. So we can see that like still 2015, so there is the trend. Similarly, for hepatitis B vaccine birth dose coverage. So if we talk about the impact of the vaccine coverage of hepatitis B rate, so as we go from 1990s till 2014 years, so as we are, it's a mandate for the 3-dose hepatitis B vaccine. So as we are going to achieve that, we can see that the chronic infections are reducing as we are achieving the 3-dose hepatitis B status. So again, then mother to child transmission. So in many endemic countries, majority of the HPV burden, as we talked about, is related to mother to child transmissions at birth or due to other exposures during early infancy. So testing of mother during antenatal period is mandatory. So HBsAg is done for expecting mothers to screen them for hepatitis B. And then in case it's positive, then there is a whole set of guidelines for the birth dose of the newborn and hepatitis B immunoglobulin, which we will go through in the next presentation. Then again, post-exposure prophylaxis of for hepatitis B. So this also in the next presentation we'll talk about in detail. But this is just that if we are previously unvaccinated, and so I'll just let it go over to Dr. Tushar for next presentation. Then hepatitis C virus. So broadly, it is hepatitis B, C, they are parenterally transmitted. But if we talk about hepatitis C virus routes of transmission, so more commonly, these are healthcare associated with unsafe blood and blood products, unsafe injections, needle stick injuries, which we come across every day, other procedures, for example, dental treatment, and then sharing of needles among persons who inject drugs, and then coming to tattoos or body piercings using contaminated equipment. So these are certain low risk categories for hepatitis C. That means that they can contribute to hepatitis C virus transmission, but at a relatively lower risk to this list that we went through for HCV. So mother to child, only 4 to 8% of babies, they acquire it from their mother if the mother is HCV positive, unless the mother is also co-infected with HIV. Other than that, it comes in the low risk for HCV transmission. So prevention of HCV transmission. So again, the modes of transmission and the prevention will be to tackle the mode of transmission per se. So the points are in parallel with that: screening of blood and blood products, injection safety, safe sexual practices, harm reduction interventions, and occupational safety. So there's no vaccine yet for hepatitis C. So the mandate is to test and treat for hepatitis C virus patients. So we have a 12-week treatment for those who are diagnosed to be hepatitis C virus positive, and there is a complete set of guidelines for treating such patients. Then these are again in tandem with what we saw in the modes of transmission of HCV. So the prevention of nosocomial transmission. So first we went through prevention of parenteral transmission, and then prevention of nosocomial transmission. So hand hygiene, safe handling of sharps and biomedical waste, safe cleaning of equipment, and screening of donated blood, and improved access to safe blood. And of course, the training of health personnel. So then there are the possibilities of co-infections like HBV, HCV co-infections, or with HIV. So prevention of these HBV or HCV transmission, like whether in silos or co-infection in people who inject drugs. So we have to raise awareness and make hepatitis B vaccine available for these patients, and provision of incentives to increase this acceptability towards hepatitis B vaccination series. So if, for example, if you want to go ahead with hepatitis B vaccination and you haven't done it so far, it is like you take one shot today, as we'll of course be going in the next presentation in detail, but you take 0 as on today, and then 1 month from today, and then 6 months from today. So 3 doses of hepatitis B vaccine in immunization. And then provision of sterile needles and syringes to those for harm reduction, and for opioid substitution therapy to treat opioid dependence and reduce hepatitis C virus risk behavior and transmission due to drug injections. Then prevention of sexual transmission of HBV and HCV. So promotion of consistent and correct use of condoms, routine testing of sex workers in high prevalence settings, and integrated action to eliminate discrimination and gender violence. And we need to increase the access to medical and social services to vulnerable persons. So before just summarizing, this is the Global Health Sector Strategy document on viral hepatitis. And if you see, these are the interventions that we aim to have in order to reduce these numbers, which we saw in the burden slides previously by Dr. Manya. So the 3-dose hepatitis B vaccine is something that we need to achieve. We are targeting to achieve till 2030 for 90%. We are aiming to achieve this 3-dose hepatitis B vaccine for 90%. Thereby also, in sync is this number: prevention of HPV prevention from mother to child transmission. So we aim to attain this number also till 90%. And then 100% blood safety, like the percentage of donation screen, we aim to get it to 100% from the current 95%. And harm reductions and other numbers. So we aim to reduce the HPV and HCV incidence, the number of new infections, by 90% by 2030. So we have still, as per 2020 targets, there were 30% reduction. So we are aiming to have 90% reduction as per this global health sector strategy on viral hepatitis. So just to summarize this presentation, that hepatitis B and C are parenterally transmitted. Hepatitis B infection in infancy and early childhood is particularly risky, as we saw, because of the risk of chronicity and the various complications that go with the chronicity of HPV infection. Then vaccination is the cornerstone for prevention of hepatitis B, particularly to prevent infection in early childhood. Bird dose followed by 2 additional doses has 90% efficacy in preventing mother to child transmission. But what we aim for is bird dose and then 3 doses at 1.5 months of age, then 2.5 months of age, and then 3.5 months of age. So, and if right now, if you want to get yourself tested and you can get your anti-HBs titer done, and this is the cutoff that we have to look for adequate protection. And then safe blood, safe injection practices, and safe sex, they are effective in preventing both hepatitis B and C virus. Thank you so much.
Thank you, Dr. Kanika Kaushal. You have very elaborately told us about the transmission and also the strategies, how to reduce the incidence, vaccination being one of those very, very important preventive measures here. I now invite Dr. Tushar Prabhakar, who will be telling us more about how the screening is done, what is the vaccination strategy, as well as what is the strategy for health education for the community. Just to introduce. Sorry, just a minute. Are you able to see my screen?
Yes, ma'am, we can.
Okay. So Dr. Tushar Prabhakar, he's a senior resident in Department of Clinical Research and Epidemiology, ILBS. He graduated from University College of Medical Sciences, Delhi, and has recently completed his post-graduation from Lady Hardinge Medical College, Delhi. During his residency, he has worked in the fields of core patient management, essential drugs and medicines, health systems strengthening, infectious and non-communicable disease epidemiology, reproductive women and child health, family planning services, malnutrition, and immunization activities. As a digital health specialist, he was the departmental representative to assist and train members in an LHMC for COVID-related data handling and operations at Delhi State Government's Data Management Portal and ComCare Delhi Fights Corona Portal. A creative enthusiast, he has won the first prize in numerous national conferences of IA, PSM and IPHA for Best Educational Video and Best Educational Meme competitions. Over to you, Dr. Tushar.
Okay, so good afternoon. The topic given to me today was viral hepatitis B and C, where we'll focus on screening, vaccination, and health education. So we'll be covering the content under the following headings, wherein first we'll talk about screening, where we'll talk about whom to screen and the various available screening tests for hepatitis B and C. And then we'll move on to vaccination in detail, where we'll talk about the types of hepatitis B vaccines available and the schedule for vaccination, what to do if somebody misses a dose of hepatitis B vaccine, and the overall coverage of hepatitis B vaccine, birth and primary 3-dose coverage. And then we'll talk about the strategies to improve the hepatitis B vaccine, especially the birth dose coverage. Finally, we'll talk in brief about the various health education aspects which we can focus in order to achieve elimination of hepatitis by 2030. So why to focus on screening? So this is a graph given by WHO and which shows the cascade of viral hepatitis prevention, diagnosis, care, and treatment. So as you can see, of the total number of people who have hepatitis, only almost half of them are available, know of their status and are getting tested. So the key interventions to eliminate hepatitis B and C, as we have already discussed, are the primary hepatitis B vaccination, which includes the childhood and birth dose, and then safe blood practices, safe injections, harm reduction. And I'll be focusing in depth about hepatitis B and C diagnosis and treatment. So the WHO Global Health Sector Strategy, it has said that in order to achieve elimination by 2030, of the total people who have hepatitis, we need to have diagnosed 30% by 2020 and raise that number to over 90% by 2030. But as we can see in the Southeast Asia region, of which India is a part, by 2019, only 10% of people with HPV have been diagnosed, and only 6.9% of HCV people have been diagnosed in 2020. So that this is by far less than the 30% that was the target set for 2020. So to increase the number of people who get diagnosed and eventually are referred for treatment, so the primary would be to screen more people. So whom should we screen? So according to the National Hepatitis Elimination Program, the screening services should be available at all peripheral institutions, which include health wellness centers and peripheral health, primary health centers as well. So anybody who walks into these centers are eligible or entitled to get free screening services. But if due to some paucity at such peripheral institutes, so we should give priority to those who are at high risk. So who are those who are at high risk? Women who are expecting mothers, injectable drug users, healthcare workers and frontline workers, people who are undergoing hemodialysis, and people with HIV. So the screening tests available for hepatitis B and C include rapid diagnostic test kits. So this is an example of a test kit. So the benefits of using these are they are cheap and they cost less than 50 rupees per kit, and they are single-use disposable assays, and they are simple to read. So any workers or staff, hospital staff working at a village level can use these screening people. They don't require additional reagents, and they can be visually read very easily, and they give a simple qualitative test quickly within 30 minutes. So these are the kits available for hepatitis B and C. So what we detect for hepatitis B is the HBs antigen in blood, and for hepatitis C, we detect the anti-HCV antibodies. So as we can see, the sensitivity and specificity for both these kits are quite high. So we can conclude that these tests are reliable. If somebody comes positive on these screening tests, we can essentially, almost to a certain extent, we can confirm that they have hepatitis, and there should be a prompt referral for confirmation and initiation of treatment. So for hepatitis B, as we have already discussed, the primary cornerstone is vaccination. So prevention is ultimately the goal for elimination of hepatitis B, especially as treatment has not been developed yet. So this vaccine, what we use is a recombinant subunit vaccine, which contains a viral protein, which is called hepatitis B surface antigen. Previously, it used to be produced from the plasma of people with chronic hepatitis B infection, but now we only use recombinant protein. So the types of vaccine available in India, firstly, there's a monovalent vaccine, and then there's a combination. So as we can see, this monovalent vaccine comes by the name of Engerix B. We can see that these are color-coded vials for adult as well as child doses. But under the government supply of Universal Immunization Program, we get the pentavalent vaccine, which we give to the children at the age of 6, 10, and 14 weeks. So this pentavalent vaccine, in addition to the hepatitis B, contains a total of 5 vaccine-preventable diseases, which is diphtheria, tetanus, pertussis, and Haemophilus influenza B. So this is free of cost under the government scheme. So however, if you go to the private setup, we have additional vaccines like hexavalent vaccine, which has an additional injectable polio virus, which has the same dosing schedule as the pentavalent vaccine. So this comes by the name of Infarix or Hexas. So if we talk about the schedule, there are 2 kinds of schedule, one for the newborn and infant up to the age of 1 year, and then there is an adult schedule. So for newborns, we need to give the 0 dose or the birth dose, which is the monovalent vaccine that we just discussed. And then at 6, 10, and 14 weeks, we give the combination pentavalent vaccine under the government scheme or the hexavalent vaccine. So this is given in a dose of 0.5 ml intramuscularly. But for adults, we have the monovalent vaccine adult dose, which is given 1 ml intramuscularly at 0, and then 1 month after the first dose, and 6 months after the first dose. So if we are giving the vaccine, so we can see that the protection rate, especially for hepatitis B in children, if we give the bird dose and at least 2 of the primary doses at 6 and 10 weeks, it effectively prevents mother-to-child transmission by over 90% in women with hepatitis B. And for children, if we give all the 3 vaccination doses of hepatitis B, we can see that there's a protection of almost 98 to 100%, which is very good, especially when now we hear that COVID vaccination provides, a good COVID vaccine provides a protection of around 80-90%. Hepatitis B vaccine is providing a 100% protection if we give all the 3 doses. So what if somebody misses a dose? So under the immunization program, the bird dose should be given immediately after birth, but can be given up to 24 hours after birth. And the primary 3 doses for childhood, they should be given at 6, 10, and 14 weeks, which can be given up to 1 year of age, provided the duration between doses is 4 weeks. So if a mother comes with a child and got the immunization at 6 weeks and then misses the 2nd and 3rd dose, she can come anytime before the child attains 1 year and make sure that the remaining 2 vaccines are given with a 4-week gap. But for adults, if the adult has got only a first dose, the 2nd dose should be administered as soon as possible. Whenever the if 1 month has passed and the person remembers, the 2nd dose should be administered as soon as possible. If he has got both first and 2nd dose, then the 3rd dose should also be given after. If the person missed the 6-month dose, so it should be given as soon as possible, provided the interval between the 2nd and 3rd dose is at least 8 weeks. So if a person comes at 0 and then comes after 3 months, so he should be given the 2nd dose right then. And then after 2 weeks of, when the person crosses 2 weeks after the 2nd dose, he should be given, 2 months after the 2nd dose, he should be given the 3rd dose. Sometimes the vaccination history is not reliable or unaware. The person is not, he can't for sure say he has received all the doses. So we can give extra single antigen monovalent doses as booster doses, as it's not harmful. So there's a question which is, should we give hepatitis B vaccine in pregnancy? The answer is yes, because neither pregnancy nor lactation should be considered a contraindication to vaccine. In fact, all pregnant women who are at risk should get the hepatitis B vaccine in order to prevent mother-to-child transmission. So who are these women who are at risk? Those who have had more than one sex partner during the last 6 months, or are being evaluated or treated for a STD. Those who are injectable drug users or have a hepatitis B positive sex partner. So when we give the vaccine, how do we ensure that it's providing adequate protection? That's by assessing the serum level. And we have already talked that a level of equal to more than 10 milli international units per ml is considered protective. So over 90% people who have this level cut off, they can be assumed to be remaining protected for the at least next 30 years. So as with any vaccine, there are some minor adverse events, even with hepatitis B vaccines, which include local pain, swelling, and fever and headache in around 3 per 100 people. Very rarely a person shows a severe hyperactive response, which we call anaphylaxis. So if a person develops anaphylaxis to 1 dose of hepatitis B vaccine, further doses are contraindicated in such people. So as per the WHO Global Health Sector Strategy for Elimination of Viral Hepatitis, we have already seen that in order to achieve elimination by 2030, the coverage of hepatitis B 3 doses of 6, 10, and 14 weeks should be 90% by 2020 and continue till 2030. Whereas the hepatitis B birth dose coverage should go from 50% in 2020 to 90% in 2030. Yeah. So in India, we can see, according to the NFHS data, which released in 2019, the primary 3-dose coverage in India was around 84%, which was quite close to the 90% target. And the hepatitis B birth dose coverage was low, around 56%. So this low percentage is common in other developing countries as well. This can be attributed to the fact that there's a high prevalence of home deliveries in such developing countries. So the window period for getting the 0 dose is missed. And sometimes there are logistic issues like absence of cold chain maintenance and vaccine availability at villages and rural areas. So we have already seen this graph. This essentially shows that as the age of contracting the infection increases, the chance of chronicity decreases. So the target should be to prevent attaining the target should be that the child does not develop hepatitis during birth up to an age of around 5 years, because the chance of chronicity is very high. So the birth dose is important, as we can see from this graph. So what to do to tackle such issues at ground level? So there's a concept called controlled temperature chain approach, which is a new approach, and studies are being conducted to see the viability of such approaches, wherein a vaccine which is heat stable can be kept outside the traditional cold chain at room temperature for up to 3 days. So we are testing some vaccines, one of which is hepatitis B vaccine. Now, a brief word on the health education aspect. In order to achieve elimination, it's very important to prevent occurrence of hepatitis B and C, and a major contributor to that is educating the people and making them aware. So there are various strategies existing. For example, exhibition of posters which say the cause and prevention aspects of hepatitis, conducting or enrolling school children in competitive competitions wherein they get aware about the hepatitis and what can be done to prevent its occurrence and the treatment available. Hiring or advocating brand ambassadors who can have a connection with the audience and take it to a large scale, involving social media, and then having campaigns like we have, ILBS has the empathy campaign and the I Pledge campaign and the Happy School, and involving stakeholders, which include government officials, to include or take up the topic at a national level. So these are some of the posters which ILBS has released. One shows about hepatitis B vaccination during pregnancy, one that shows hepatitis C is curable, one shows about the vaccination birth dose being important. A cartoon competition was held in 2019, which involved school children from over 40 countries, and it was a big success. This is a Happy School campaign, which was started in 2019, wherein all the government school principals and one teacher in Delhi were invited to attend a 1-day workshop at ILBS, and we hoped that they could further disseminate the knowledge to their peers and students in the government schools of Delhi. The I Pledge campaign, which promotes people to take up an oath to work upon strategies and cheap interventions to prevent occurrence of hepatitis and treatment if they get the disease. We have a brand ambassador, Mary Com, who helps dissemination of the knowledge regarding hepatitis to the masses, and she's a national celebrity. We have had conclaves with stakeholders in the parliament to take up the program at a state and national level and include it in the viral hepatitis program and new initiatives. Faculty videos are available on social media like Twitter and YouTube. And to summarize, we talked that diagnosis is a key bottleneck, and screening is the key strategy to increase the diagnosis and effectively increase the number of people getting treatment for their hepatitis. Rapid diagnostic tests are easy to use, and they provide quick results. They're cheap, they have high specificity and sensitivity, so should be used widely. The primary 3 dose of hepatitis B vaccine is a very good method to prevent occurrence of hepatitis, as it provides around 98 to 100% protection. And for mother to child transmission, a birth dose and 2 primary doses prevents mother to child transmission in hepatitis B positive mothers by over 90%. And a titer of equal to more than 10 milli international units per ml is considered adequate protection. Thank you.
Thank you. Thank you so much, Dr. Tushar. You have given us very valuable information on how the screening should be done, what is the vaccination schedule for children and for adults, and of course, what is being done as a strategy to promote improved awareness among the community. I now invite Dr. Rahul Gehlot, Project Officer Empathy, to please administer the I Pledge. Dr. Rahul.
Thank you, ma'am. Now may I request all the panelists to please switch on your camera, raise your right hand and repeat after me so that we can proceed with the pledge. I pledge that I will talk and generate dialogue about hepatitis B and C.
I pledge that I will talk and generate dialogue about hepatitis B and C.
I pledge that I will spread awareness and educate people about hepatitis B and C.
I pledge that I will spread awareness and educate people about hepatitis B and C.
I pledge that I will try to keep my liver healthy.
I pledge that I will try to keep my liver healthy.
I pledge that I will get myself and my family tested and vaccinated.
I pledge that I will get myself
tested and vaccinated.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will generate dialogue with my colleagues on hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will teach 10 people about hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will not discriminate people living with hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
I pledge that I will contribute in empowering people against hepatitis.
Thank you. Over to you, ma'am.
Let's contribute in empowering people. Thank you. Now I hand over to Dr. Aisha to conduct the plenary session.
Thank you so much, ma'am. So initially, we'll take up a few common questions that are generally asked, since we have a couple of them. So we'll start with those. Dr. Namrata, if you could share the PPT.
Yeah, in the meantime, there are some questions that were posted in the Q&A box. Thank you so much, Dr. Aisha. So there were a few questions that have been posted in the Q&A box. And once again, I encourage all the audience, the participants, to please post your questions in the Q&A box, which you may be able to locate in your Zoom platform panel. There have been certain queries which were very actively answered by our speakers, especially Dr. Manya. So thank you so much for that. And the participants are again encouraged to post your questions in the Q&A box. In the meantime, we will take up few general questions which are most frequently asked from our participants from the webinars. The most frequent query that we have coming into us is regarding the lactation. Can hepatitis B and C positive mother breastfeed the child? And Dr. Kanika has very expertly managed to handle this question. So once again, can you please shed some more light on this? Can hepatitis B and C positive mother breastfeed the child?
Yeah, I mean, there is absolutely no contraindication for breastfeeding a child if mother is hepatitis B or C positive. But all we have to see is the one is the integrity of the skin. There should be like no cracked nipples, which are bleeding nipples, which is common in breastfeeding mothers. So apart from that, there is no contraindication for this. Yeah.
Thank you so much, Dr. Kanika. And I'd asked Dr. Tushar to answer the second question. What to do if I've missed second dose of HPV vaccination? Should I go for third dose, which you did cover in your presentation also? But the most common question that we get from participants is that should they start their cycle from dose 1, or how to go about it if they've missed the dose after the first dose?
So if the person has got 1 dose of vaccine, so he should continue from the next dose and should not restart from the first dose. And provided, if we are talking especially about children, if the age for the primary 3-dose vaccine, if the child has crossed the age of 1, then we don't give the vaccine. So unless the child is 1 year of age, we can continue from where we left off.
Thank you so much for answering that. I'd asked Dr. Manya to kindly address this next question. That is, how soon after exposure to HPV will symptoms appear, and what should be the post-exposure prophylaxis?
So it's highly variable. The incubation period is very, very variable. And the virus may lie inactive without any symptoms for many years also. With regard to post-exposure prophylaxis, of course, Dr. Tushar covered this very, very nicely. There's no need to panic. There's a standard protocol which is provided in the guidelines for the program as well, which includes testing and some drugs, and a standard protocol has to be followed. So the first thing is to not panic.
Thank you so much, Dr. Manya, and quite importantly highlighted the first thing is not to get panicked and get more knowledge and be rather more aware about what to and how to go about it. And such webinars definitely do underscore the such questions and address such challenges that most of the people face. The next question is, if I may request Dr. Umesh to please answer this question. If I have got infected with hepatitis C 10 years ago, which was cured with treatment, what chances of contracting it again?
Thank you, Namrata. Before I answer this question, I'd like to emphasize 2-3 things for the participants. One is that we have a universal vaccination policy, irrespective of the age, sex, and physiological status. Everyone should get vaccinated. So there's no question of who should get vaccinated, high screen, high risk, low risk. No, nothing. Everybody should get vaccinated in our country. That's number one. Number two, there are only 2 contraindications. There are only 2 contraindications for breastfeeding globally. One is if the mother is suffering from postpartum psychosis, where she's not aware about what she's doing. And second is carcinoma breast. There is no other contraindication for breastfeeding to the young one, because the risk of dying of a child is much, much higher if you don't breastfeed the child. Right? So these are the 2 most important things which I thought I must re-emphasize. Coming back to your question, once a person takes 8 weeks of therapy for, say, hepatitis C, the viral load reduces to minimal level, and that is treated as cured. So if a person has hepatitis C 10 years back, this is the standard protocol. And Dr. Manya would like to add something.
No, sir. That's it, sir. Thank you.
Over to you.
Thank you so much, sir. Thank you, sir, and thank you so much for again re-emphasizing on the need for breastfeeding, especially in a country where the lactation and the practices, there is early weaning in the children, especially in metropolitan cities. So the next question that we have from one of our audiences is that are there any provisions in government facilities and centers to get vaccinated?
There are number of centers where the vaccines are available. And like in Delhi, we have a GB Pant hospital, which is a nodal agency, nodal hospital for Hpv vaccination. They can go and take vaccination there. Plus, it is gradually being spread out to many other centers, nodal centers, where the hepatitis B vaccination is available. That's number one. All the government primary health centers and sub-centers, they have hepatitis B vaccination for the infants, newborns. We are giving almost 4 doses during the infancy. So they are available there also. And we do have some of the districts where 95% of the newborn are vaccinated with HPV. But still, we have a lot of path to cover, because if you look at the DPT vaccination is about 90%, 95%, but HPV vaccination is up to level of 60%, because there are transportation issues, logistic issues, storage and so on and so forth. So we do have these issues, but Government of India is trying its best that vaccine should be available at each and every healthcare facility. Thank you. Over to you.
Thank you so much, sir. We do have another question that has been posted. Can we not stop permanently rapid test because I have found false negative in, I believe this has been quite immaculately answered by Dr. Manya already. So if the audience have some more questions, please feel free to post them in the Q&A box that you may locate in your control panel of the Zoom platform. Well, it is a pleasure to have to hear from Dr. Umesh, and he has been spearheading he has been pioneering a lot of health programs in at national level in nutrition especially. So I don't think anybody else can answer this question better than you, sir. The question that is very frequently asked is, there are a lot of diet and subtypes of diets that people follow, but what are the absolute necessary changes which are most crucial for hepatitis B positive patients that they need to make? The absolute necessary changes.
Look, it's a very simple and straightforward. The Indian traditional diet is the best in the world, right? Dal, roti, chawal, seasonal vegetables, seasonal fruits. It is rich in all the micronutrients, all the minerals. It's rich in calories, rich in dietary fiber, everything. So what is important is that we must stick to the traditional Indian diet. Now, if we change to a diet which is high protein or anything, it is not possible, because you may do it for 2 months, 3 months, 4 months, but then again you will come back to your traditional diet. You cannot have a separate food to be cooked for you in the family. So we must understand that we must have food from the family pot. That's number one. An Indian traditional diet is the best. If you look at, and I would go a step further, Indian traditional vegetarian diet is the best. If you look at all the cancers are much, much less in our country as compared to Western world, because our diet is rich in dietary fiber. It is a balanced diet. Only question is, we are becoming newly rich and we are trying to add more fats and oil. Look what is happening. When you go to a fast food restaurant, you eat burger which doesn't have any dietary fiber. हमें रोटी 3 खाते हैं, ठीक है, पूरी 5 खाते हैं, और बिल्कुल जो अच्छी वाली पूरी होती है, जो मैदे की बनी होती है, वो 8 और 10 भी खा लेते हैं पर भूख नहीं मरती। इसका कारण है कि उनमें डाइटरी फाइबर नहीं होता। व्हेन यू ईट डाइटरी फाइबर, it goes to your stomach and hits the satiety center, and then you stop eating because your satiety center is through. But if you eat burger, you keep on eating more and more burgers. आपका भूख नहीं मरता उससे. So what is important is we must remember that Indian traditional diet is the best, and hepatitis B patients do not require anything specific that they need a high protein diet or high mineral diet. No, just relax. I'm talking about the public health intervention for the entire country. Yes, however, if we go for a single patient, one-to-one patient, then it's a doctor who decides that what type of diet should be prescribed to a particular person depending upon his nutritional status. Thank you. Over to you, Namrata.
Thank you so much, sir, for very elaborately touching on the topic, especially the fast foods. For some reason, all the good tasting food is either fried or fattening. But then, good point that you covered regarding the satiety centers. So thank you so much. We don't see any further questions in the question and answer panel. And I thank the speakers for very wonderfully addressing queries and in-depth covering the aspects of the questions that were asked. In case if Dr. Sidhu would like to add some points regarding the nutrition, you're most welcome, ma'am. So I'm handing over to Dr. Aisha.
Ma'am, you need to unmute.
I agree with Dr. Kapil. He's talked about low fiber diet and therefore poor satiety, and people go on eating. When it comes to hepatitis, in hepatitis A, there is lack of appetite and increase in bilirubin and whatever else. So उसमें तो भूख नहीं लगती है, तो आप कुछ भी नहीं खा पाते. उसमें force करना पड़ता है high carbohydrate food को, कि hepatic cells damage ना हो and hepatic cell का regeneration हो, तो high carbohydrate diet देनी पड़ती है, because वो actually appetite falls. But जहाँ ये chronic हो जाता है hepatitis, तो it is no doubt patient to patient basis depending on what the patient is able to take. If there's carbohydrate intake falls, it has to be promoted. Otherwise, the rule of the thumb is that when it comes to liver diseases, we do not give long chain triglycerides. So, and the fat which is absorbable MCT form, that is given. So fried food to सवाल ही नहीं पैदा होता. तो so there are specific kind of guidelines of so-called liver diseases. The rule of the thumb is to go on high carbohydrate diet, not high enough to increase glycemia, but a high for a good hepatic regeneration, and low fat, especially long chain, and increase in MCT, and so there are, and the other part, the protein is generally taken to be just a good one so that the hepatic regeneration takes place. So high quality, good quality protein. High means meeting the normal requirements. So that doesn't change from hepatitis A, B, C, D, E. So, but patient-wise, kai baar wo modify karna padta hai, and it is nutrition counseling at the end of it. The larger picture is if for prevention and etc., we should not get into their nutritional status. Otherwise, wo to by and large is by vaccination, hygiene, and there are other ways of precaution. That is the focus today. So we can talk diet on some other day, and we can talk through diet, nutrition also another day. And when it comes to hepatic regeneration, things like vitamin C and vitamin A, which improves epithelial cell integrity, and vitamin E, and the age, because you don't give to very small children, but you give vitamin K to small children. So it changes from age to age, person to person. So that is so I'm sorry, I'm talking a little extra on this nutrition thing. It just kind of, kickstarts a nutritionist to how they think. And today's emphasis is very important, to have a general guideline, people's sensitivity to understand. And so every line should, we take an oath on, we highlight those 10, 11 doable points. 6 you have enumerated. The doable points so that it's easy to recapitulate and drum it to the community. Ki ye baat yaad rakhni hai. And when they go on drumming it, the rest follows. So they become particular about practice. Ki ye 6 kaam karne, to अगर आपने उनको प्रैक्टिस मोड पे डाल दिया तो वो नॉलेज भी सीख ही कर लेंगे और खुद ही मॉनिटर भी करेंगे कि ये हम क्यों कर रहे हैं, तो वो मॉनिटर भी कर पाएंगे. So I think drummable messages are a key thing, and thereafter we start with behavior change communication on those key messages. So I really look forward to the remaining proceedings. Pulkit, yeah, back to you.
Yes, thank you, ma'am. And I think we've had a really good discussion. We've had excellent presentations, starting with Dr. Sidhu, who gave the keynote address, and after which we have looked at the burden of the problem. We have looked at how the hepatitis B and C viruses are transmitted, how we can protect them, what is the screening process, what is the vaccination strategy. We have all taken part in the pledge that we will look after our livers. I now take this opportunity and this privilege of proposing the vote of thanks. I would like to thank all the participants who took their time out of their busy schedules to join us today for this very important webinar. Big thank you to Dr. S.K. Sareen, Vice Chancellor, and Dr. Umesh Kapil, Professor, Department of Epidemiology and Clinical Research, Institute of Liver and Biliary Sciences. This is indeed a very wonderful and very important initiative, sir, that you are leading. Thank you so much for making us, as Lady Owen, a part of this campaign. Dr. Tushar, Dr. Manya, Dr. Kanika, thank you for your very informative presentations. And we wish the Empathy Project team all the best in their endeavors. Dr. Namrata and Dr. Aisha, thank you very much for coordinating and helping organize this whole program and making it a big success. I wish to also place on record my big thank you to my director, Dr. Anupa Sidhu, for her admirable vision in actually steering Lady Irwin College towards new initiatives, and for her constant support and encouragement that she gives to the Department of Food and Nutrition and Food Technology to work in the area of public health and nutrition. Thank you so much, one and all, for being here today.
Thank you.
Thank you so much, ma'am, for your kind and warm words and helping. And I would really like to thank Dr. Sidhu and Lady Irwin College for helping us in achieving our endeavors and making this webinar a success. And I'm very thankful to all my speakers who take out time from their busy schedules and are always up for the webinars that we take. And a sincere thanks to Dr. Umesh Kapil for initiating these webinars and taking this to a very different platform altogether, and definitely my colleagues Dr. Namrata and Dr. Rahul and the entire team of Empathy. So this has been a good ride so far, and now I request all the participants to please take the post webinar survey. The link has been posted in your chat boxes and also will be available on your screens. There will be a link and a QR code, so you can choose to go either way, and please fill the post webinar survey, and after that you will be getting your certificates in a couple of days. You can also be a part of the Empathy campaign through this email ID. You can write to us. We will be looking forward to your queries or any feedback, or any way you can lend a hand to Empathy empowering people against hepatitis. We would be very glad if you could write back to us, and it has been a wonderful webinar. Thank you all. That will be all from my side, ma'am, and we'll leave the screen to this so that people can actually fill the survey, and that will be all. Thank you.
Thank you.
The post webinar link will be open for a while, so you can take your time, and we would sign off from here, but the link will be available, so you can go through it, fill the questionnaire, write back to us.
Bye-bye. The bug.
Thank you so much, ma'am. Thank you, Dr. Pulkit.
Thank you.